Hey, Assalamu alaikum, guys. My name is Rida Shahab. I'm a second year medical student, and today I'm going to be teaching the physiology of the female reproductive system. This is going to be a fairly easy session because Dr. AJR took it and his slides are really direct. So I took everything from his slides. But if you have any questions throughout the session, please feel free to text me at my number or just ask in the chat box. So these are our table of contents. So we're going to be starting off with sex determination, the changes during puberty, oogenesis, the female reproductive system, external genitalia, and then ending it with some questions. So let's start. Bismillah. So we're going to be starting with the sex determination. So what determines the sex in the fetus? So we have a gene called SRY gene, which is basically the sex determining region on the Y chromosome, which is responsible for the initiation of the male gonadal differentiation. So if SRY gene is present, this is gonna differentiate the gonads into testes. So the fetus is gonna be male. But if the SRY gene is absent, then this is going to differentiate the gonads into ovaries, which makes the sex of the fetus female. So no, one second. So no SRY gene is going to lead to the fetus being a female. Okay, so that's the first point. Now, coming on to the genetic basis. So we know that the female chromosome number, we know that we have 23 pairs of chromosome, right? And the sex gametes are XX in females, and we just discussed what SRY gene is. So in females, there is no SRY gene, and the gonads are going to differentiate into ovaries. So how do the internal genital structures develop? So you know how in males we have Sertoli cells. Now these Sertoli cells are going to release anti-Mullerian hormone. And this anti-Mullerian hormone is what's going to regress the Mullerian duct and basically let the Wolffian duct grow. This is what happens in the male fetus. But in the female fetus, we don't have Sertoli cells. So there's going to be no anti-Mullerian hormone, which basically leads to the growth of Mullerian duct. And this Mullerian duct is going to give you the fallopian tube, the uterus, and the upper portion of the vagina. So the main takeaway from this slide is the females don't have Sertoli cell, which is why we also don't have anti-Mullerian hormone. And when we don't have anti-Mullerian hormone, the Mullerian duct is going to grow. And the Mullerian duct is going to give you the different parts of the internal genitalia, which is going to be your fallopian tubes, your uterus, and your upper portion of the vagina. Now, coming on to this picture, Dr. AJR had in his slides, we're going to focus on this part of the picture because we're talking about the female reproductive system. So the female reproductive system, we know it's SRY negative, right? Which is going to lead to the development of the gonads into ovaries. Now, the ovaries don't have anti-Mullerian hormone. There's going to be absent anti-Mullerian hormone, which is going to make your Mullerian duct grow, which is going to further grow into the uterus, the fallopian tube, and the upper vagina, as we discussed. The ovary also release estradiol. Now, what's estradiol? It's basically estrogen. It's a form of estrogen. So this estrogen is going to further help in the growth of the clitoris, the labia minora, the labia majora, and the lower vagina. Okay, this is what is here. Now, coming on to the third point, we discussed this in the picture just now. So we're just going to talk about the role of estrogen again. We just say, okay, the ovaries produce estrogen or estradiol, which helps in the differentiation of the external female structures, such as the lower vagina, clitoris, labia minora, and labia majora. Okay, this picture just discusses the same thing again. So I'm going to just go over it real quick, just so you guys have an idea of what every picture in his slides is talking about. So no SRY gene is what's going to lead to the gonads developing into the ovaries. The ovaries are going to undergo oogenesis, which is basically the process of the formation of the eggs. So the oogonia is the germ cell, which is then going to find the primary oocyte. The primary oocyte is going to be surrounded by the granulosa cells, make the primordial follicle. It's going to be surrounded by the theca cells, and it's going to make the antral follicle. I know it sounds a lot, but it's going to make more sense when we cover the oogenesis part. Now, since we don't have any Sertoli cells, we're not going to have anti-Mullerian hormone, which is going to lead to the development of the Mullerian duct, which is going to give you your internal genital structures, such as the oviduct, uterus, cervix, and our vagina. Now, because we don't have dihydrotestosterone, it's going to give you your external genitalia, like clitoris, labia minora, labia majora, and your outer vagina. So that's about sex differentiation. Now, coming to the time frame of the female development. So here we're just going to look at the time frame of the female development from an embryonic point of view. So at 7 to 12 weeks, we're going to have the meiosis of the oogonia, and it's going to get arrested into the first meiotic prophase. We're going to be discussing this, so don't worry. But just remember that 7 to 12 weeks is where the sex gametes start forming, okay? We're going to have ovarian organogenesis, which is when the ovaries start forming. You're also going to have the formation of the primordial follicles. And 11 to 12 weeks is when you're going to have the oviducts, the uterus, the cervix, and the external genitalia with the vagina starting to be formed. And then 20 to 25 weeks is where the primary follicles in the ovary are going to be formed. Okay. Now, changes during puberty. So, what changes will the female body undergo during puberty? So, what exactly happens here is the timing of the puberty is totally influenced by how much body fat is there. So, if the person is thin, they're gonna hit their puberty later. But if the person is healthy or athletic, they're gonna have their puberty early on. Okay, this is because the adipose tissues they have an expression of this hormone called aromatase, which basically converts your androgens to estrogens, which is gonna help in puberty. And leptin, which is also a hormone released by the adipose tissue, it has a permissive role in hypothalamic maturation at puberty. Now, what does this point mean? This basically means that the leptin is going to tell your brain that the body has enough fat and it can undergo puberty. Okay, so this is what permissive role means here. Permissive just basically means allowing. So it's going to allow your body to get into puberty. And that's what adipose tissue or leptin here does. Now, a few years before menarche, which is onset of menses, adrenarche happens. Now, adrenarche is basically when the sex steroids or adrenal glands just get mature. So they're released sex steroids, which is going to lead to the growth of the pubic and the axillary hair. Okay, so adrenarche happens and then menarche happens. Okay, now a landmark of female puberty, which is very important, is also the onset of mammary gland growth, which is called telarchy. So at puberty, the estrogen causes the enlargement and the darkening of the areola. Now, areola is basically the hairless circle which surrounds the nipple, okay? And there's also going to be some ductal growth beneath the areola and the nipple because we know that mammary glands have ducts. So you have telarchy, which is the growth of the mammary glands. You have adrenarche, which is when the adrenal glands get mature, they release sex steroids, which is going to help in the formation of your pubic and axillary hair. And you have menarche, which is the onset of menses. Okay. Also, when the ovulatory cycles begin, progesterone is going to stimulate further growth and the maturation of the mammary glands. So ovulatory cycle is when ovulation happens in the female. That's when progesterone is going to further stimulate growth and maturation of the mammary glands. Here are the key takeaways. So we discussed estrogen and progesterone kick before menses, adrenarche, telarchy, we discussed these terms. Okay, for Tanner stages, now what are Tanner stages? Tanner stages, these are basically just stages that evaluate the growth of the teenager. So it's gonna just tell you the different stages of puberty, okay? That's where Tanner stages is. So we're gonna compare the Tanner stages in the female and then the male. So first we're gonna talk about what the Tanner stages in female are. So we have pubertal growth spurt, which is earlier in girls compared to boys. Now, growth spurt basically here means is the sudden growth. So, when puberty hits, there's just sudden growth. That's what growth spurt here refers to. So it's earlier in girls compared to boys. So girls hit puberty faster than boys. And the growth spurt is regulated by T3, growth hormone, and IGF. So T3 is released by thyroid, growth hormone is by pituitary, and IGF is by liver. Okay, and your sex steroids. So this is what's going to regulate the puberty or regulate the growth of the person. Now, estradiol, which is also estrogen, it promotes normal bone density. Now, this point is really important because this is just a fun fact, and you're probably going to take this as well. In menopause, the estrogen drops, right? And because estrogen is dropping here, this is what leads the women to be more prone to osteoporosis. Because estrogen in itself, it promotes normal bone density, so it makes the bone stronger, right? But in menopause, since menses stop, the estrogen is going to fall down and the female is going to be more prone to osteoporosis. This is where it just connects, okay? So you need to know that estrogen just promotes normal bone density and makes the bone stronger. Now, these two pictures here are just the different Tanner stages. So here in this picture, we're just talking about when the normal height range happens like at a puberty. So the normal height range is from like 9.5 years to 14.5 years. This is when the height usually hits the person. For menarche, it can start anytime between 10 to 16 years of age. For breast stage, it can start anytime from 11 to 15 years of age. And 2, 3, 4, 5 are just different Tanner stages that we're going to talk about. Pubic hair stage is from about 11.5 years to 14 years. Okay. For Tanner pubertal stages in female, the main focus we're going to have is going to be the breast and the pubic hair, because breast telarchy is the hallmark of your development or your puberty in females, right? So there are 5 stages that we're going to be talking about in Tanner stages. Stage 1 is the prepubertal stage. This is when the puberty has not hit. Stage 5 is the maximum puberty, like the puberty has hit and everything is just there, right? So stage 5, the breast is going to be the adult breast. The pubic hair is going to be the adult type hair with triangular shape distribution. And stage 1 is just a pre-pubertal stage, so it's just you're not gonna see anything there. So these are the 2 stages here. Between stage 1 and stage 5, we have 2, 3, 5. Sorry, we have 2, 3, 4, right? And stage 2 in the breast, you're just gonna see a breast bud, which is the hallmark of the female puberty. And there's also gonna be a papilla elevated. And stage 3 in the breast is where you're gonna see the enlargement of the breast mold. And stage 4 is where the areola and the nipple start getting elevated, and then your adult breast forms. For pubic hair, stage 2 is where there's going to be slight growth of fine, downy hair. And then at stage 3, this hair is going to get darker, it's going to get denser, it's going to get coiled, okay? Stage 4 is where the adult type hair comes, but the area that it's covering is less than that in stage 5. So in stage 5, we have a triangular shape distribution, but in stage 4, it's like the area is just a little bit less. So that's stage 4. Now comparing the Tanner stages, so the Tanner stage is assigned independently for genitalia. So regardless of the person being, let's say, hypothetically at a stage 2 for breast development, they can be at stage 3 for the pubic hair development. So it doesn't have to correlate to each other, okay? So coming here, we can see at stage 1, this is the pubertal stage. So there is no breast bud formation, there's no hair, no pubic hair in both the cases. Stage 2 is where the pubic hair starts appearing. Pubic hair appearing is also called pubarchy, okay? Adenarchy is when the adrenal glands like when the adrenal glands mature and release the sex steroids, which is gonna help in the growth of the pubic hair. But pubic hair in itself, if it's there, it's called pubarchy, okay? Then in males, you're going to see the testicular enlargement along with the pubic hair, a little pubic hair as well. Then the breastbud in the female also forms just telarchy. Stage 3 is where you're going to see the penis size is going to increase, the breast is going to enlarge, and there's also going to be a coarsening of the pubic hair, so it's going to get darker, it's going to get denser, right? And then in stage 4, you can see that there's going to be the formation, the breast is going to enlarge. The penis is also going to, like the width and the length of the penis is also going to enlarge, and also your pubic hair is going to cover most of the area, but it's not going to be as it's not going to cover most of the area as it does in stage 5. And then in stage 5, you can just see that the organs are all developed, okay? And the earliest detectable secondary sexual characteristic is breast bud development in girls, so telarchy, and testicular enlargement in boys, okay? Now, this is basically the important sum of terms that we talked about. So we talked about menarche, which is the onset of the first menstrual period, which happens between the age of 10 to 16. We have telarchy, which is basically development of the breast. Adenarche, which is the maturation of the adrenal glands. Pubarchy is the appearance of the pubic and axillary hair, which is related to adenarche, but they're not the same terms. Okay, going to the oogenesis. Does anybody have any questions before we go to oogenesis? Okay, I'm going to take that as a no, and I'm going to move on. So oogenesis is basically the process by which the female gametes, or the eggs, develop into ova, which are produced in the ovaries. Now, this is basically the bulk of the lecture, so I need you to concentrate here with me because this is really important. So we're first going to focus on the picture right here, and then we can cover the text later on. Okay, here. Let's focus on the picture first. So there's going to be two events that we're going to be focusing on. We're going to be focusing on the mitotic events and then the follicular development in the ovary. So these happen like together, okay? So three stages that we're going to be focusing on are going to be before birth, at birth, and then at puberty. So before birth, what happens is you have the oogonium, which is a stem cell. Now, this oogonium is going to undergo mitosis, and it's going to further divide itself. So it's going to make primary oocytes, which are still going to be diploid. They're not haploid yet. Haploid is going to be when they undergo meiosis. So they first undergo mitosis, they make duplicate copies of themselves. They're going to form primary oocytes. Okay. And then this primary oocyte is gonna go, this primary oocyte is inside primordial follicle, right? So now coming to the follicular development in the ovary, you have the primordial follicle, which is gonna contain this primary oocyte. This primary oocyte is gonna undergo meiosis 1, right? And we have two meiosis cycles happening. Why do we have two meiosis cycles happening? Because we need genetic variation in the gametes, okay? So this primary oocyte undergoes meiosis 1, and we know meiosis has 4 different stages, right? We know it has prophase, anaphase, metaphase, telophase, right? So it's prophase, metaphase, anaphase, telophase. Okay, so the primary oocyte, as soon as it undergoes meiosis 1, it's going to get stuck at prophase 1. So primary oocytes are going to get stuck in prophase 1 in meiosis 1 at birth. Okay, this is where they're gonna get stuck at, and they're going to be inside the primordial follicle. So what is the primordial follicle going to consist? The primary oocyte, which is stuck at prophase 1 in meiosis 1. Now, this is when the female hits puberty, right? When the onset of menses start. This primordial follicle is further then going to divide into primary follicle and secondary follicle because of the surge of FSH, which is follicular stimulating hormone, and LH, which is luteinizing hormone. This happens with the onset of menses, when the menses start. And as soon as it goes into secondary follicle, the primary oocyte is then going to complete its stage of meiosis 1, and it's going to go into meiosis 2, and it's going to get stuck at metaphase 2. So Graafian follicle is going to have your secondary oocyte that is stuck in metaphase 2 of meiosis 2, okay? And it's going to release this ovulated egg, which is called ovulation, and this can go two ways. So it's going to release the secondary oocyte with the first polar body, okay? Now this secondary oocyte can either get fertilized by a sperm, or it doesn't get fertilized because there's no sperm, okay? So here is what happens if it gets fertilized. Now, hypothetically, let's say a sperm comes and it fertilizes the secondary oocyte. The secondary oocyte is then going to get converted into the ovum and the second polar body. And this ovum is going to then fertilize with the sperm and make the zygote. Okay, this is what happens if there's a sperm. But if there's no sperm, this secondary oocyte is going to degenerate, basically. And the female body is preparing itself for an egg, regardless of fertilization or no fertilization every month. And because there's no implantation of this egg, the endometrium of the uterus breaks down and the menses happen. It's going to make more sense when you talk about the uterus, but this is just the basic overall view of what's happening. Now, this Graafian follicle has the secondary oocyte, right? And we said when ovulation happens and the egg is released out of the Graafian follicle, it can go two ways. What happens to the Graafian follicle? The Graafian follicle is gonna get degenerated into corpus luteum, regardless of fertilization happening or not happening. Okay, so if fertilization happened, there's still going to be corpus luteum. If fertilization does not happen, there's still going to be corpus luteum. So the Graafian follicle just degenerates itself into corpus luteum, and the secondary oocyte can undergo two different pathways, as we discussed. Coming on back to the text, so we know the oogonia formation. We said oogonia are basically the germ cells that divide by mitosis in the embryo. We just discussed that. They differentiate into the primary oocytes, and then they're going to undergo meiosis 1, and they're going to get arrested in prophase 1. So this is before birth until puberty. So before birth until puberty, the female is going to have primordial follicles, which are going to contain primary oocytes that are stuck in prophase 1 of meiosis 1, okay? So at birth, a female usually has 1 to 2 million oocytes. So we have a finite number of oocytes. Now, puberty onward, we said FSH and LH are going to stimulate the follicular growth. There's going to be a dominant follicular that continues this meiosis 1. So it's going to complete the meiosis 1, and it's going to reach meiosis 2, and it's going to get stuck at the metaphase of meiosis 2. Now, as soon as it completes meiosis one, it's going to make a secondary oocyte and a first polar body. So a secondary oocyte is going to be in the Graafian follicle. Okay, now it's going to be arrested in metaphase 2. Now, if fertilization happens, this meiosis is going to get completed. Okay, this meiosis cycle is going to get completed and it's going to make the ovum, the second polar body, and then the ovum is going to fuse with the sperm and make the zygote. But if there's no fertilization, the egg is going to get stuck at metaphase 2 and it's just going to degenerate. Okay, so here fertilization happens, there's going to be completion of the meiosis 2. It's going to make the haploid ovum, which is going to fuse with the haploid sperm and make a diploid zygote. Okay, and that's what the last point says. Yep, that's pretty much it. I hope it's clear. If it's not, you can ask me questions. Okay, so coming to the female reproductive system, the female reproductive system is gonna basically produce ova, as we said, for fertilization, and it's also gonna support your embryo implantation, your fetal growth, and your birth. So this is going to be regulated by hypothalamic pituitary ovarian axis, which is HPG axis, with ovarian hormones such as estrogen, progesterone, that's going to control it via negative feedback, except mid-menstrual cycle. So in menstrual cycle, this estrogen and progesterone, usually estrogen and progesterone, they're going to have a negative feedback on LH and FSH. So if estrogen is high, LH and FSH are going to be low. But in mid-menstrual cycle, when the follicles are growing, they're going to release high estrogen. And instead of a negative feedback, it's going to have a positive feedback. And this high estrogen is going to lead up to high FSH and LH surge. Basically, that's what this point means. The reproductive years, they're going to extend from menarche, which is the onset of menses, to menopause, which is when the menses stop. So menopause is basically defined as 12 months without menstruation. And it's just going to continue, like you're not going to have menses at all for the entire rest of the life, right? The ovarian cycle is going to involve the follicular growth and development, which leads to ovulation. We just talked about that. After ovulation, the follicle, sorry, is going to transform into the corpus luteum, which is going to secrete progesterone to maintain early pregnancy. So regardless of fertilization happening or no happening, the Graafian follicle is going to get transformed into corpus luteum. And if fertilization does happen, this corpus luteum is what's going to maintain the high levels of progesterone in pregnancy. Okay. The uterine cycle also occurs in parallel, which prepares the endometrium for implantation, as we said, for the fertilized ovum. So every month, the female body is preparing itself for the implantation of the egg. And if it doesn't happen, the wall breaks down and there's going to be menses. Okay. Now, ovarian and placental hormones also sustain pregnancy and prepare the breasts for lactation. Coming on to the female reproductive system, we're just going to discuss this picture real quick. So this is the uterus here. Okay, okay, you guys can see it. Then there is the ovary right here. This is the fimbriae, which are finger-like projections of the oviduct. This is the oviduct, which is also called the fallopian tube. Here is the suspensory ligament of the ovary, which basically connects the ovary to the pelvic wall, so the ovary is stable. Okay, you're gonna also have this is your bladder. This is gonna be your Bartholian glands. We're gonna discuss this. This is gonna be your hymen. This is your labia minora, and this is your labia majora. And then this is your vagina. This is your anus at the back. This is your cervix. And that's pretty much all you need to know. You just need to know the uterus, the cervix, the vagina, the hymen, Bartholian gland, obviously the ovary, the fimbriae, the oviduct. Yeah. So now coming on to the female reproductive system. So we know the female reproductive tract does not directly connect to the ovaries because it has fallopian tubes, which are also called oviducts, but are connecting it to the ovaries. Now these internal ducts are what's gonna consist of your paired oviducts. So you're gonna have two fallopian tubes or oviducts which are paired. You're gonna also have the uterus, the cervix, and the vagina. The external genitalia surrounds the external opening of the vagina. So this is the external genitalia, and it's going to surround the external opening of the vagina. Now, the female ovary has two functions. So it's going to have oogenesis, which is basically the formation of the egg, and it's going to have secretion of the sex steroids. Now, secretion of the sex steroids is basically progesterone and estrogen, okay? The ovary in itself, it's going to have three zones. So we're going to have the cortex, we're gonna have the medulla, and we're gonna have the hilum. So the hilum is basically your blood vessels and your lymphatics that are going to nourish the ovary. We're going to have the medulla, which is basically, it's going to be just a mixture of stromal connective cells. Okay. And your cortex. Your cortex is going to be what contains, it's basically lined by the germinal epithelium, which is going to contain the oocytes, which are enclosed in a follicle. So this is what's going to happen here. And this is your corpus luteum, which is after the graphene follicle degenerates. So this is your graphene follicle. It's going to release the ovulated oocytes. It's then going to develop into corpus luteum. This is your corpus luteum. Okay. Now, coming on to estrogen and progesterone. Estrogen and progesterone have paracrine and endocrine functions. What is paracrine and endocrine? Paracrine is when they are supplying like nearby tissues or nearby cells. Endocrine is when they enter the bloodstream, right? So estrogen and progesterone, they enter the bloodstream and they also supply the nearby tissues or nearby cells. So in the ovaries, they're going to support the development of the ova, the granulosa cells, and the thecal cells, which is going to make more sense when you take the follicular development. But basically, it's just going to help in the follicular development. In the blood, they're going to act on the uterus, the breast, and the bone. We talked about the bone. It's going to help in the growth of the uterus, and it's going to help in the growth of the breast. Now, the functional unit of the ovary is the ovarian follicle. Okay, and this is made by germ cells, that are encircled by endocrine cells. So when it's developed, it's the follicle and the sex steroids have several critical roles. Now, what are these roles? They're basically going to provide nutrients to the developing oocyte that is inside the follicle. It's also going to release the oocyte at ovulation. It's going to prepare your vagina and the fallopian tube to aid fertilization of the egg and the sperm, basically. And it's also going to prepare the lining of the uterus for implantation. And if there's no implantation or if there's no fertilization, this lining is going to break down. Okay. So if fertilization does occur and there is pregnancy, it's going to maintain the hormone levels for the fetus until the placenta takes over. Okay. So here we're going to discuss the oviduct, which is also called the fallopian tube. The oviduct or the fallopian tubes are basically muscular ends that are opened at both the ends, basically. Now, because they're open at both the ends, they have like finger-like projections, which are called fimbriae, which are going to hold the ovary. Okay. And this oviduct is divided into 4 sections. So the first section we're going to talk about is the infundibulum, which is with the fimbriae. And then you're going to have the ampulla. And ampulla is the main site for fertilization. We have isthmus and we have intramural or your uterine segment. So the egg is going to travel like this, and the sperm is going to come from here, and they usually fuse here at the ampulla. And then the zygote is going to undergo like different stages, and then it's going to make a blastocyst. This blastocyst is going to travel back into the uterus and get implanted here, and that implant window has like 3 days. Okay, so the endosalpinx, which is the inner lining of your fallopian tube, is a simple epithelium that consists of the ciliated and secretory cells. Now, cilia is basically finger-like projections that aid in movement. So it's going to basically aid in the movement of the egg to the uterus, okay? And that's what this sentence says. The fimbria or the cilia, they permit the transport of the ovulated cumulus oocyte complex, which is just a big chunky word for egg, of the female, and it just moves the egg into the oviduct to the uterus. Okay, now this capture of the egg here at ovulation and transported to the ampulla and isthmus junction with the cilia, it is a site for sperm storage. So this site is usually for the sperm storage, and it remains viable by attaching to the epithelial mucus of the isthmus. So this is how the sperm stays viable. And the fallopian tube fallopian tube secretions is what's going to induce capacitation and hyperactivity of the sperm so that it can go and fuse with the egg. Okay, now as we said, it's going to move the embryo into the uterus, which has an implantation window of 3 days. And we also talked about the blastocyst stage. We said the oviduct is going to maintain the early embryo up to blastocyst. So it's going to maintain the early embryo here till like the blastocyst stage, and then it allows it to move into the uterus and get implanted, which gives it an implant window of 3 days. And also the oviduct secretions support and nourish the pre-implantation embryo. So the secretions in the oviduct is gonna nourish the embryo before implanting. Now, a clinical section that Dr. AJR covered, which is really important, is a primary ciliary dyskinesia, which is also called immotile cilia syndrome, which is when your cilia or your flagella is affected. So there's going to be non-motile cilia, right? There's going to be abnormal beating or just loss of cilia in general. So this disease is characterized by infections of the upper respiratory tract, the nasal tract, and the middle ear, and it's responsible for 50% cases of infertility. Why? Because we discussed the cilia is what's going to help move the egg and like the zygote or the blastocyst in general to the uterus. Now, let's say there is fertilization that happens, there is zygote, but there's no cilia that can move it to the uterus for implantation. This is why it's going to cause infertility. So it's important to know this. So the cilia in the uterus, it basically just fails to move the egg towards the fallopian tube, which causes the female infertility. Now, coming on to the uterus, we said the uterus is between the bladder and the rectum. We saw that in the picture, and it consists of a body and the cervix. So this, the superior aspect is called the fundus, while the portion which is like towards the end or like adjacent to the cervix or like around the cervix is called the isthmus or the lower uterine segment. Now, the hormones are going to regulate the endometrium thickness. So you have three walls or three layers in your uterus. You have endometrium, you have myometrium, and you have perimetrium. So endometrium is the layer that's going to get thickened um, every month for the implantation of the embryo. But if there is no embryo to get implanted, this is the wall that's going to shed and then start the menses. So the main functions here include of the endometrium include the implantation of the blastocyst or of the uterus. It includes the implantation of the blastocyst that occurs in the endometrium. It also limits the invasiveness of the implanting embryo, so it stays in the endometrium. It doesn't want the embryo to get implanted anywhere else because that's going to be called an ectopic pregnancy, and it just really difficult for the embryo to grow anywhere else except in the uterus. It also provides the maternal side of the mature placenta. So the mature placenta is just going to give nutrients to the developing embryo. It's also going to grow and expand during gestation. So the fetus is in the uterus, it's going to expand, it's going to take its own space, and the fetus develops in basically non-adhesive or an aqueous environment. It's also going to promote or provide strong muscular contractions to expel the fetus out at delivery. Coming on to the cervix, cervix is basically the inferior extension of the uterus that's going to lead into vagina. So this is the cervix, this is the uterus, this is the cervix, and then it's going to lead into the vagina. So at mid-menstrual cycle, the endocervical canal, which is towards the inside, like the endocervical canal is here, right? It's going to facilitate the sperm viability and entry. So the cervix is what's going to facilitate the sperm entry into the uterus, and then it's going to go to the fallopian tube. Now, there are two stages that you're going to learn. There's going to be follicular stage and the luteal stage. Now, what's very important to know of these stages is in follicular stage, there's going to be high levels of estrogen. This high levels of estrogen is going to stimulate a thin, watery, slightly alkaline mucus that's going to facilitate the sperm movement. So it's going to help moving the sperm into the uterus, into the fallopian tube to have fertilization. But during the luteal phase, which is the second stage of the cycle, the cervix is going to block the passage of the sperm. So there's going to be no sperm entry into the female reproductive tract at all. So there's going to minimize infections. So it's going to kill all the microbes. It's not going to let sperm enter, and it's just going to protect the female reproductive tract altogether. So follicular stage, estrogen is going to release a thin, watery, slightly alkaline mucus. In the luteal phase, it's usually progesterone that releases it releases a scant viscous slightly acidic mucus that's not going to let the sperm enter into the female reproductive tract. So it's hostile to the sperm and it does not form. So in this picture, it can be a bit tricky. In this picture, it is ferning. So this is not the luteal phase. This is the follicular phase. This picture is going to show you the follicular phase because in the picture you can see that it's ferning. So this is most likely the estrogen stage or the follicular stage. But if it's not ferning in the picture, then it's most likely the luteal phase, which is where the progesterone is going to basically make an acidic mucus where your sperm cannot pass into the female reproductive tract. Okay, so the endocervical tract or the endocervical mucus can act as a sperm barrier as well, right? And in pregnancy, this is what happens because in pregnancy there's going to be high placental progesterone, which is not gonna let any other sperm enter because there's already an embryo that's growing inside. Okay, and this transformation zone, which is where the glandular epithelium changes to squamous epithelium, is the site for cervical dysplasia and malignant transformation, which basically means it's the site for cervical cancer. This is where most cancers can happen, which is the transformation zone. Now, coming on to the vagina. Now, the vagina is the organ in the female reproductive tract that acts as the birth canal. Okay. Now, there are no glands in the vagina, but the lubrication during intercourse comes from three different ways. So there's going to be cervical mucus that we talked about, especially during mid-cycle, that is released by your estrogen. There's also going to be transduate, which is just the ultrafiltrate from the blood vessels that are going to secrete, there's going to secrete fluid. And there's also going to be vestibular glands, like Bartholian glands that we talked about. And the vaginal wall is innervated by pudendal nerve, which contributes to the sexual pleasure as well as orgasm during intercourse. Now, estrogen is what's going to stimulate the proliferation of the vaginal epithelium. So it's what's going to cause the thickening of the vaginal epithelium, and it's going to increase the glycogen content. Now, we know when there's menopause, estrogen drops. What happens in estrogen? Well, if we say that estrogen proliferates the vaginal epithelium, it helps the vaginal epithelium thicken. If there's menopause and the estrogen drops, then during menopause, the vaginal epithelium is going to thin. So, like, there's going to be thinning of the vaginal epithelium. It's not going to be thick anymore. There's also going to be reduced glycogen content. And what glycogen does is it gets metabolized into lactic acid, and this lactic acid is just going to maintain like an acidic environment, which is going to inhibit infections. So in menopause, the female is going to be more likely to infections because there's going to be no glycogen production because of low estrogens. Okay, so there's going to be higher infection risk. There's going to be symptoms like dryness and dyspareunia. And there's also going to be increased vaginal pH because there's going to be acidic environment. Okay, there's also going to be progesterone that increases the desquamation of the epithelial cells. That's about the female reproductive tract. Is there any questions so far? Or can we move to the last part of the lecture? I'm going to wait for like 2 minutes to see if anyone has any questions, and then we can move on. Okay, I'm going to take that as a no, and we're going to move on. So we have the external genitalia, which is the last part of the lecture. The female external genitalia is basically surrounded by labia majora and labia majora laterally, and the mons pubis interiorly. Okay, and the vulva here is going to include the labia majora, the mons pubis, labia minora, the clitoris, and the vestibule of the vagina. So here it's going to be pons pubis, that's anteriorly surrounding the external genitalia, and there's going to be labia majora that's surrounding the external genitalia laterally. Okay, and yeah, that's all you need to know here. This is the anus, this is the vestibule right here, and this is your urethral orifice, this is your hymen, and then this is your vaginal, this is your Bartholian or the vestibular glands that's going to secrete secretions. This is your clitoris, and the clitoris is the homologue of the penis, and it's involved in sexual arousal and the climax at orgasm. So basically, the clitoris in the female is the homologous of. Can you guys hear me, or is my internet connection not stable? Okay, guys, I thought it was my connection was not stable. Okay, so we have yeah, we just discussed that the structures of the vulva functions in sexual arousal as well as orgasm, which directs the flow of the urine and it closes the vaginal opening, which prevents the entry of pathogens. So you don't want anything infecting your like the passage of the vagina. And that's pretty much it. And now we have questions for practice. So we're gonna do the questions. So maybe does anybody have any questions so far? It's a fairly easy lecture. It's really direct. So it's not that complicated. So we're gonna go into the questions. The first question is, in the menstrual cycle, as menstruation bleeding ends, the estrogen levels in the blood rise rapidly. Which one of the following is the source of the estrogen? The answer is C, the developing follicles, because as we said, the developing follicles is what's going to increase the levels of estrogen, and then the cycle is going to continue, and then there's going to be a high LH surge and FSH surge. Okay, so the second question here is, the research laboratory of a fertility clinic investigates various biomolecules for their ability to induce sperm capacitation. The molecules have been most likely isolated from the fluid of which of the following structures? So, which fluid? It is uterus. So uterus basically more specifically it's going to be oviducts because there's going to be secretion from the oviducts that's going to help in the capacitation of the sperms. It's uterus, specifically oviducts. Okay, so the development of gonads into testes or ovaries is determined by which of the following? This is a little bit tricky, but try the eliminating technique. It is A, yes. So TDF is basically the testis determining factor, which is part of your sex determining Y, which is part of SRY, which is your sex determining gene. And that's pretty much it. Thank you guys so much for attending. Please scan the QR code for the feedback form and let me know if you guys have any questions. You can always text me on my number if you have any questions and feel free to reach out whenever.